Good evening. The topic of discussion for today is acute kidney injury. This is compactly not given in standard textbooks because the etiology of AKI itself is a big topic, majority of the etiologies. So in this video, I tried to compile the information about AKI under the following heading. What is it? What are the stages, classification, causes, pathophysiology, diagnosis, management and complication. Before going into the definition of AKI, whenever there is a senior examiner, there will be always question on this one. Why the previous name acute renal failure have been changed into acute kidney injury? Because this acute kidney injury, previously they have thought it as a kidney failure which is happening in a short period of time. But later they have found out it is not a specific entity of failure. There is some insult to the kidney which result in its dysfunction. So that's why the name have been changed to acute kidney injury. So if we see the definition, it refers to the abrupt decrease in the kidney function which occur over hours to days, resulting in retention of the urea and other nitrogenous waste product, and also in the dysregulation of the extracellular volume and electrolytes. But this definition doesn't contain any diagnostic criteria. So in 2012, the KDIGO, which is the International Organization for Making the Nephrology Related Guidelines, they have made this to diagnose AKI. One of the following three criteria have to be met. The first one is rise in 0.3 milligram per deciliter over a period of 48 hours. That is the absolute rise in creatinine, or more than 1.5 times the baseline within the previous 7 days, or decrease in the urine output to the level of less than 0.5 ml per kg per hour for 6 hours. So this is the 2012 KDIGO recommended definition for AKI. So combining these two, so the definition that a resident have to say is acute kidney injury. It refers to the abrupt decrease in the kidney function resulting in retention of urea and other nitrogenous waste product, and is defined by at least 0.3 milligram per deciliter rise in creatinine over a period of 48 hours, or more than 1.5 times, or you can say as 50% rise in creatinine from the baseline value within the last 7 days, or the decrease in urine output to 0.5 ml per kg per hour for past 6 hours. So this is the exact definition of AKI. Next, regarding the stages and the classification. Before that, the timeline of the renal dysfunction one have to be clear with. As we see, if it is the starting of the renal dysfunction, as I have told, AKI is the renal dysfunction occurring within hours to days. So less than 7 days is AKI. As we know, the structural and functional abnormality of the kidney for more than 3 months is CKD. In between the period, it is called as RPRF, rapidly progressive renal failure. Some textbook or literature have mentioned this as acute kidney disease also. So this is the timeline of renal dysfunction the resident should be aware of. Once we take the classification or staging of the acute kidney injury, there were various attempts to refine the classification. The three important guideline or the classification we are having is, first one is the rifle, which was the historically the initial one. This you might have studied during your UG time, which is risk, injury, failure, loss and ESRD. This have urine output and creatinine based criteria. This also have creatinine and urine output based criteria. This also have creatinine and urine output based criteria. Loss is need for renal replacement therapy for more than 4 weeks. ESRD is renal replacement therapy for more than 3 months. So again, here you can just remember as 50% rise in creatinine, 100% rise in creatinine, or 200% rise in creatinine compared to the baseline. Then comes the AKI. So there is a question, when AKI is there, why the KDIGO comes? There are fine refinement in the classification or staging of these REFAL and AKI. Then currently we are following KDIGO. Here also stage 1, 2 and 3 is there, which is in parallel with the rifle RIF. These two category are not here. Here also we are having creatinine and urine output based criteria, creatinine and urine output based criteria. Here also we are having stage 1, stage 2, stage 3. One important difference I want to mention over here between AKIN and KDIGO is AKIN have mentioned either 0.3 milligram per deciliter rise in creatinine or 50% rise in baseline, both under 48 hours. Whereas in KDIGO it is changed, either 0.3 milligram rise over 48 hours, 50% over 7 days. This is one difference between AKIN and KDIGO, at least a medicine resident should be aware of. Next, stage 2 is 100% rise in creatinine from the baseline, 200% rise in creatinine from the baseline, or the urine output less than 0.5 ml per hour per kg for 6 hours, for 12 hours, for 24 hours. Here also almost everything is same. Few additions to the stage 3 both in AKIN and KDIGO is, if the patient requires renal replacement therapy, that is dialysis, the patient goes directly into stage 3. If the creatinine is more than 4, then also the patient goes directly into stage 3. If the age is less than 18 years and the eGFR is less than 35, then also he goes into stage 3. This is important at least for MCQ point of view. So overall, 3 classification system: rifle, AKIN and KDIGO. Why the new changes come? Because of the fine refinements. Not going into the details of fine refinements, just I am saying AKIN and KDIGO. Currently we are following the KDIGO classification, stage 1, 2 and 3. And the urine output criteria is same for all the 3. In summary, this is the summary slide. Whatever I discussed, as we see here, rifle 50% rise in creatinine, 100% rise in 200%. So for AKIN also either 50% rise or 0.3 milligram per deciliter, 100% rise, 200% rise. KDIGO also stage 1, stage 2, stage 3, again the same. This urine output criteria, 0.5 ml per kg per hour for 6 hours, for 12 hours is stage 2, for 24 hours is stage 3, or anuria for 12 hours is stage 3. Along with that, need for RRT, creatinine more than 4, age less than 18, eGFR less than 35 is also stage 3. So this is with respect to the staging of AKI as per KDIGO. This one we have to follow. And in few textbook, instead of mentioning this as percentage, they mention as 1.5 times, 2 times, something like that. That is just to show you how the textbook have mentioned it. See, if we take rifle in the stage 1, rise in creatinine 1.5 times the baseline, 2 times the baseline, 3 times the baseline. In AKIN also, they have mentioned as 200 times 152, basically 1.5 to 2 times, 2 to 3 times, more than 3 times. Here also almost similar, 1.5 to 1.9, 2 to 2.9, more than 3 times. So just for the medicine resident, you just remember this: 50% rise in baseline, 100% rise and 200% rise. This is easy to remember. What are the risk factors for AKI? Does all the patient develop AKI? No, there should be some risk factor. What are the important risk factor? Age, even a male gender itself is a risk factor. Any chronic kidney disease on the background. So the term we use is acute kidney injury on a CKD patient. So proteinuria, diabetes, sepsis, volume depletion, CLD, hyperuricemia. These are some of the risk factors for AKI. Traditionally, the cause can be classified as pre-renal, the insult occurring in the kidney, and the post-renal. This thing, the classification, one point you have to clearly understand is the pre-renal, renal and post-renal. The terms pre-renal means the insult is occurring before the kidney, but whatever the pathophysiological changes occurring is within the kidney. This you have to be very clear with. This I will discuss once I am discussing the pathophysiology. Then only you will understand the concept of fractional excretion of sodium, and sepsis comes under both pre-renal and renal. Why it is like that? That I will discuss. First, we will see the pre-renal. Pre-renal causes can be secondary to the volume loss. Volume loss can occur because of severe vomiting, diarrhea, diabetes insipidus, inadvertent use of diuretics in a volume depleted patient, blood loss secondary to road traffic accident, upper GI bleed, lower GI bleed, third space loss in the form of pancreatitis, burns, effective circulatory pressure. If there is a decrease in the effective circulatory volume, as in nephrotic syndrome, sepsis. Why nephrotic syndrome? Because in nephrotic syndrome there is no albumin within the blood vessel because it is lost in the urine. So all the fluid goes into the interstitial space. So the effective circulatory volume is less. So because of this, what happened? The patient might have pre-renal component type of injury to the kidneys. Afferent vasoconstriction in the form of drugs like NSAID. These are all the major etiologies in the pre-renal category. Coming to the renal, intrinsic renal insult. If we take the kidney component as I shown here at the cut section of the kidney, here you are seeing the glomeruli. The glomeruli can get affected. Here is the interstitium. The interstitium can get affected. The blood vessels can get affected. The tubules can get affected. The four components of the kidney can get affected, which might result in acute kidney injury. That is the glomeruli, interstitium, tubular or the vascular component. Any of the component have any pathology might lead to this kind of AKI. For example, glomeruli, there might be glomerulonephritis. Any inflammation of the glomeruli. Acute glomerulonephritis, nephritic syndrome, acute interstitial nephritis, thrombotic microangiopathy, any tubular injury. These four itself is a separate topic. At least for the purpose of AKI, remember these injury can cause renal dysfunction. Under the acute interstitial nephritis, the three major causes are drugs. It can be dose dependent or dose independent. Infection, infiltration in the form of any malignancy or myeloma. This tubular necrosis, the terminology is a misnomer. There is no necrosis. There is some kind of cellular disruption that result in the renal dysfunction. The major etiology of toxin. Toxin can be exogenous from outside or endogenous. Third one is ischemia. Ischemia, the reduced blood supply can cause tubular necrosis. So this slide I kept only to show you the important etiology of the acute tubular necrosis. Endogenous toxin, exogenous toxin in the form of drugs, in the form of myoglobinuria, hemoglobinuria. That's why the etiology keeps on going for AKI. That's why book, if you see in Harrison, the topic looks somewhat not specific because they used to discuss one point from each of the etiology. That's why you can't get a hold of the topic. So see, there are three broad categories which can cause AKI. Coming to the post-renal. If we take the post-renal part, the kidney, from the kidney urine forms, urine gets to the collecting tubule from the pelvic calyceal system to the ureter, bladder, urethra, external genitalia outside. So obstruction can occur anywhere. It can be occur externally because of some compression or internally. Internally, the most important is renal stones. Externally, any mass, cancerous mass can affect. One important thing a medicine resident should be aware is neurogenic bladder. Whenever the bladder is not compliant, the kidney urine will come above. It causes reflux and obstructive neuropathy. Bladder outlet obstruction in the form of prostate, stricture urethra, bilateral ureter stones. These are all the common causes you have to be aware of. Once you remember the anatomy of the kidney, you can easily make up the causes. To make up the causes, I have kept this slide also. You can go through what are the intrinsic and extrinsic causes of obstruction. So this table is from the standard nephrology textbook Figali, where whatever the etiology I have discussed is mentioned over here. Pre-renal approximately cause of 60% of the AKI. It is mentioned as pre-renal. The insult is occurring before kidney, but what are the pathophysiological changes? It is occurring inside the kidney. Okay. So first is volume depletion, decreased cardiac output. Look at sepsis. Sepsis is given here also, and in the intrinsic also. So that's why I am mentioning you regarding the pre-renal insult. Intrinsic cause around 40% of the AKI, as I told, acute tubular necrosis, acute interstitial nephritis, glomerulonephritis. Yeah, vessel can be involved. Vessel can be in the form of thrombotic microangiopathy or large vessel in the form of bilateral renal artery stenosis or severe hypertension. So these are all the broad categories. Obstruction, as I told, extrinsic and intrinsic obstructions are there. So we have seen AKI, under which we have seen the broad categories of the pre-renal, renal and intrinsic renal. Now going into the pathophysiology. If we take the pathophysiology of the AKI, as per the etiology, the pathophysiology varies. First, we are going to see the pathophysiology of pre-renal AKI. To understand the pre-renal AKI, you should remember one important homeostatic physiological function mediated by the juxtaglomerular apparatus, that is tubuloglomerular feedback. What is that tubuloglomerular feedback? In the distal tubule, whenever there is an excessive supply of sodium through the JG cells, there is a constriction of the afferent arteriole. This point you have to remember from the physiology point of view to make you understand the pre-renal component of the AKI. See, here is the blood vessel. Most of the functioning nephrons are in the cortex. The cortex is being supplied by the cortical vessels. The vessels are located like this. As I shown here, the blood vessels are located over here. Whenever there is a volume depletion, the blood supply to this area goes down. So, as we see here, around the glomeruli there are blood vessels. So what happens whenever there is a decreased volume or any blood loss? The cortical blood supply goes down. The blood supply to the cortex or the nephron goes down. Whenever there is a hypoxia, this X3 segment of the proximal convoluted tubule and the medullary limb, basically first step is the proximal S3 segment and the distal convoluted tubule are more prone for hypoxia. So what happens? There is a dysfunction of this area which leads to cell disintegration, and here there won't be any absorption. The sodium gets released into the tubules. What happens in the distal limb? Here is the macula densa which senses the excessive sodium through the juxtaglomerular apparatus. It causes constriction of the afferent arteriole. So there is a reduction in the GFR. So here there is damage to the tubule in the proximal convoluted tubule, excessive sodium, the blood supply to the nephron comes down. So eGFR goes down, creatinine starts rising. What happens when the blood supply to the nephron is stopped? There is no further filtration of sodium. Creatinine will get secreted, but there is no filtration of urea, because creatinine some component gets secreted also. So that is why the blood urea nitrogen rises more than creatinine. The ratio is more than 20:1. I will come to that later. But as of now, you should remember there is a damage to the tubules over here. Excessive sodium supply to the distal macula densa. It detects and sends negative feedback to shut down the blood supply afferent arteriole. So there is no further loss of sodium, no filtration occurs, only secretion can occur, the creatinine secretion can occur. These kind of insult occur in pre-renal component. Is the sodium getting excreted? No. After the initial sense by the macula densa, it sends signal to the afferent arteriole to stop further excretion. So there won't be any excretion because the filtration is not occurring here. So the FENA is nothing but how much sodium is going in the urine. As of now, you remember like that. Fractional excretion of sodium in the urine is less in pre-renal component. Theoretically, what is happening whenever there is a renal ischemia? There are vascular effect, not only hypoxia, because of the stagnant of blood, high calcium will be there, which also causes vasoconstriction, and also there is an endothelial injury. All these lead to decreased GFR. There will be release of reactive nitrogen oxidation species also. All this leads to decreased GFR. First is the vascular factors. Second is the tubular factor. What happened to the tubule? Whenever there is a hypoxia, these kind of tubules are there. This will go for polarity loss, integrin. The cell adhesion get lost. The pump, sodium potassium pump is also lost. Finally, it goes in disintegration. So there is no reabsorption of sodium. There is a apoptosis can occur. In acute interstitial, that is regarding the pre-renal component, at least for the medicine resident, what they should be aware of. Now coming to the next component, if we take the intrinsic renal, whenever there is a glomerulonephritis, the entire glomeruli getting inflamed, there is no filtration occurs. You can remember like that as of now at least. For acute interstitial nephritis, there is the inflammation of the interstitium. CD4 rich infiltrates are coming because of some kind of injury, either drug or exogenous infection, something. There is no particular tubular damage, as I told, particular site of nephron being affected in pre-renal. Here, the particular site is not affected, the entire interstitium is getting affected. So the sodium in the urine might be normal only because the macula densa is not activated, it is not detecting excessive salt, so the sodium might be losing at the normal rate. So the fractional excretion of sodium might be high. And the other components, as I told, creatinine, since if in the glomeruli or the interstitium part, both the components getting affected equally. So there is no separate creatinine secretion. Bilirubin is not, urea, BUN or urea is not getting filtered. It is nothing like that. All the components getting affected equally. And each component of the AKI is having its own pathophysiological things, but at least you have to be aware of the pre-renal one and the renal one. Renal, all the components might be getting affected. For example, glomeruli might be getting affected as a whole. Interstitium might be getting affected of the tubular injury. Coming to the one more thing regarding the pathophysiology is post-renal. Post-renal, whenever there is an obstruction to the urinary flow, there is a back pressure building within the pelvic calyceal system. It reduces the filtration pressure. There won't be any filtration occurring because there will have to be some filtration pressure. What happens in obstructive uropathy? There is a pressure building from the opposite side. So it reduces the filtration occurring, it reduces the GFR. So this is overall regarding pre-renal, renal and post-renal. And what are the other specific form of AKI? One is acute cortical necrosis. As we see the kidney, Because of the severe blood loss or the toxin, the entire cortex gets necrosed. It is not only the nephron blood supply, entire kidney blood supply is gone. The entire cortex got necrosed. Sometimes UTI, pyelonephritis can cause sepsis related AKI. Myeloma causes COST. The causes obstruction of the tubule. Excessive light chain goes inside the tubule and get obstructed. And contrast induced nephropathy. These also causes AKI. Each itself is a separate topic. So very difficult to discuss the pathophysiology within a very short period of AKI. Just you remember these are also condition causes AKI. AKI is a big umbrella under which so many etiologies are coming. We are discussing one by one. We have discussed the pathophysiology of the pre-renal component, which is very important. Coming to the diagnosis. For the diagnosis, history is very, very important. What are all the insulting factors? For example, vomiting, diarrhea, any toxin you have taken, what is the past history, diabetes is there or not, hypertension is there or not, it's very important. Examination, blood pressure, pulse, from everything you will get the clue. Blood loss, low BP, tachycardia, volume loss, high BP, vascular mediated injury, volume status, bilateral pedal edema or periorbital puffiness might indicate nephrotic syndrome. You have to take a detailed history as per the etiology. Then you have to go with the investigation stepwise as per the etiology. First you have to get the complete blood count to look at the hemoglobin, any autoimmune process if it is there, patient might be anemic, kidney function test, in the liver function test, albumin is very, very important in the case of AKI because we have to look at whether the glomeruli is involved or not. If the glomeruli is involved, there will be loss of albumin in the urine. Electrolytes, sodium, potassium, calcium, magnesium, phosphorus is very important. ABG to look for the acid-base status. Urine routine microscopy to look for the presence of RBC or protein. Because presence of RBC, dysmorphic RBC indicates there might be glomerular involvement. It is not that in tubular injury and acute interstitial nephritis there won't be any RBC. RBC can be seen, but you have to make your differential diagnosis. If the RBCs are seen, high chances of acute glomerulonephritis. To look at the kidney to rule out any obstructive uropathy. Complement level whenever you are suspecting glomerulonephritis. Because glomerulonephritis we have to see whether a complement is activated or not. So C3, C4 level is very important. And with respect to the urea creatinine, how to differentiate between pre-renal and renal, I will tell you. And autoimmune markers, if the patient is a young female, ANA, ANCA level, as per the history only. If the patient presented with hemoptosis, anti-GBM is anti-glomerular basement membrane antibody disease, Goodpaster syndrome you have to evaluate for. That's why history is very important. It is not a blanket investigation things that you have to compulsorily do in AKI. It is not like that. It has per the history and the diagnostic outcome. That's why the concept of AKI and etiology is very, very important. Biopsy whenever there is a suspicion of the etiology. If there is a clear-cut history of the AKI, if the insult is very clear, for example, a patient has taken some drug, within 3 days patient developed this, most likely acute interstitial nephritis, no need for biopsy. Most of the times biopsy will be required if you think glomerulonephritis, if the diagnosis is going to change the treatment. So if you do biopsy, you have to look at light microscopy, immunofluorescence microscopy and electron microscopy. In obstructive uropathy, it might not be required, just relieve the obstruction, it will be cleared off. And one more point I want to show here is the creatinine, which is a marker to find out the renal dysfunction, is basically a late marker. Whenever there is injury, there is a window period of 48 hours, then only the EGFR first starts coming down. Once the EGFR reaches the critical level more than 50% loss, then only the creatinine start rising in the case of AKI. So that's why creatinine is a late marker. So that's why the researchers are going on to find the novel biomarkers to find the acute kidney injury at an earlier state. At least in this lecture, just remember these are all the name to find out the acute kidney injury under the research purpose. Kidney injury molecule 1, neutrophil gelatin associated lipocalcin in the plasma and the urine, interleukin 18, fatty acid binding protein, TIMP, and IGFP. So these are each itself is a separate topic, or you might get this novel biomarkers of AKI in the 4th paper. Regarding this biomarker, I will make a separate video, at least just for time being. You remember these are all the biomarkers available for AKI. Now going into the diagnostic approach as given in the standard nephrology textbooks. See, whenever there is elevated creatinine, first you have to baseline kidney function, you have to check whether the patient is fitting into AKI or CKD. If the patient is having a previous creatinine value, that is 3 months back, that means patient might fit into CKD only. So basic history is very important. Then look at the creatinine. If the creatinine is high, always rule out obstruction first. Do the kidney ultrasound, rule out obstruction. If there is obstruction, treat the obstruction, AKI will improve. The management stops there. If there is no evidence of obstruction, look at the history, examination, and if you suspect pre-renal kind of injury, correct the volume loss, correct the blood loss, the patient will respond, the patient will improve. That's all. It is done. Suppose if the patient is having, if you think intrinsic kind of injury, you have to evaluate it for glomerulonephritis, interstitial nephritis, or vascular kind of injury, or the tubular kind of injury. So you have to ask the particular history. This is the time the patient might require biopsy, autoimmune markers might be required. You have to pick up the clue from the urine routine microscopy, whether RBCs are there or not, eosinophils there or not. The clue is in case of tubular injury, in case of interstitial nephritis, there might be presence of eosinophils in the urine. In case of thrombotic microangiopathy, there might be presence of cystiocytes, sickle cell cells, platelet might be low. These are all the clues you will get. That is how you have to approach a case of AKI. Now coming to FENA and the typical UG level questions, how to differentiate between the pre-renal and the renal. As I told, even though the name is pre-renal, the injury, as you saw, it occurs in the S3 segment of the tubules only. So as I told, in the tubule, whenever there is a damage over here, excessive sodium goes to the macula densa. It stops the blood supply to afferent arteriole vasoconstriction. So there is no further sodium loss. So whenever there is a pre-renal injury, what is FENA? FENA is fractional excretion of sodium. How you are checking? Urinary sodium by plasma sodium. You are just comparing the sodium. This formula is confusing for many students out there. It is nothing but you are comparing urine sodium with plasma sodium. At least for standardization, you are using the creatinine. You are comparing with urinary creatinine, you are comparing with the plasma creatinine. Because this formula, many students get confused. So this is how you have to approach. You are comparing urinary sodium with plasma sodium. That's all. For standardization, you are using the creatinine. So if you put the formula as per putting the denominator and bringing it above, so it goes upside down. So the formula comes. As of now, you remember urinary sodium by plasma sodium. So what happens in the pre-renal component of injury? There is no further filtration because the afferent arteriole is getting constricted. So FENA, sodium in the urine, is less than 1. What happens to the urine specific gravity? It might go high because urine is very concentrated. Urine osmolarity might be high because there is no further secretion of the filtrate, only whatever remaining is getting secreted concentratedly. And one more thing is, creatinine is being secreted and the urea is not being filtered. So urea goes high, creatinine is getting secreted at the average level. If we compare urea and creatinine, the rise of urea or the bun, you can say, it is very high compared to creatinine. That's why bun creatinine ratio is high. Whereas in intrinsic renal, there is a whole damage, either the glomeruli or interstitium is getting affected. There is no mismatch. Both rise simultaneously. Is the FENA is foolproof? Is it the diagnosis of choice to make pre-renal? No, it is from the history only. Most of the time in our clinical practice, we won't do FENA. It is theoretical. If we have doubt, then it will give the clue what kind of injury is happening. There are some kind of pre-renal factor, as you see here. If we use diuretic, even in pre-renal condition, the FENA might be more than 1. So that's why understanding pathophysiology is very important. Even in the intrinsic renal injury, the FENA might be less than 1 because of the radio contrast or rhabdomyolysis. Why FENA? It basically depends on which kind the tubule are getting involved. What is the macula densa, how it causes afferent arterial constriction, then the FENA might vary. So if we go by the theoretical discussion of pre-renal and renal, as we see here, as in the pre-renal there is a loss. Here there is exposure of drugs. Glomerulonephritis can also cause hypotension, might be there. Here there won't be anything. Bun creatinine ratio is more than 20. See, bun is half of urea, so they might use urea creatinine ratio also. If we use urea creatinine ratio, it comes as 10. Muddy brown cast, the WBC cast are non-specific, whereas muddy brown cast is very specific for acute tubular necrosis. Regarding the urinary cast also, I will make a separate video. And urinary osmolality, as I discussed, it's a concentrated urine. Urinary osmolality is high, proteinuria might not be there. In the tubular damage, there will be mild to moderate proteinuria. Urine sodium is less, FENA is less than 1, FENA is more than 1. Even if we take the excretion of urea also comes less, so the value is 35. These are basically for the MCQ purpose, but concept you have to clear with. The excretion of sodium, excretion of urea gets decreased if there is a pre-renal insult of injury. Coming to the clinical feature. As a medicine third year resident, at least you people are aware what happens whenever there is a AKI. Very easy to say, the patient will go in volume overload. There will be dysalactolemia, he might be having hyperkalemia, conductive defects in the heart, hyponatremia, hypernatremia, and all the uremic manifestation. Uremic pericarditis, uremic coagulopathy, uremic gastritis, uremic encephalopathy, any kind of these things can happen. Malnutrition, they are prone for infection because of the systemic dysregulation. The patient might go for congestive cardiac failure because of volume overload. This you can, at least you are aware of this. Coming to the management. Basically management, you have to look at the etiology, correct the etiology or treat the etiology. That is the main management. Whenever the patient develops indication of renal replacement therapy, we have to give dialysis in the form of laboratorical hyperkalemia, potassium more than 6, severe metabolic acidosis, pH less than 7.1 or bicarbonate less than 5, or any uremic manifestation. There is no specific urea creatinine cutoff to start the dialysis. It is a clinical decision. Urea, usually more than 180 patients are more prone for developing uremic manifestation. At that time you have to think of the renal replacement therapy. Another one is volume overload. You have to think of these conditions. So there is an algorithm which is given in the nephrology textbook. You can see over here. First, whenever there is a life-threatening complication, just start RRT. Suppose if the patient potassium is more than 7, at that time you can't be waiting to find out the etiology. Just first give the dialysis, save the patient, then you can think of the etiology. Volume status have to be corrected. If there is a toxin which is causing the kidney injury, have to be corrected. Rhabdomyolysis, myeloma, if it is there treated, any acute factor, especially sepsis. In India, the more common etiology to cause AKI is sepsis. In gynecological ward, blood loss, post-surgery, drug-induced, these are all the things you have to take care of. You have to monitor the acid-base status, metabolic and the fluid status. And this is one important table to show drugs which have been tried in acute kidney injury. Dopamine, phenyldopa, norepinephrine, loop diuretic, N-acetylcysteine, statin, insulin, adenosine antagonist, erythropoietin. There are multiple drugs has been tried, but what is the result? None of the drugs shown to have any benefit in AKI. So at least as of the year 2023, no standard guidelines says to use any specific drugs in AKI, especially dopamine. Many of the medicine resident in the ICU, they always have the doubt, sir, should I start dopamine? Like as per the pathophysiology of dopamine, it causes vasodilation. Yes, you can convert, in the RCT have shown no benefit. So these drugs tried but no benefit. What complication can happen other than that? The AKI, there is a risk if it is not properly treated, can go into CKD. Don't look at all this. This is for DM entrance and all. I will discuss about these things in a separate video. Just at least remember, AKI, if not treated properly, might go into CKD. Few points about the acute renal replacement therapy. What are the options available if you are deciding to start the patient on dialysis? Just a minute. What are the options are available? First is commonly used in our wards, intermittent hemodialysis. We are giving hemodialysis intermittently daily 3 to 4 hours and we are stabilizing the patient. Another option is continuously we are giving the patient because of the hemodynamic dysfunction. Regarding CRRT, I have made a video. If you didn't go through, you can see that. Third is peritoneal dialysis. Peritoneal dialysis is also equally effective as hemodialysis. As per the patient profile, we have to decide upon. Fourth is hybrid therapy. Hybrid therapy is giving hemodialysis for a prolonged duration, also called as PIRRT, prolonged intermittent renal replacement therapy, or SLET, slow low efficacy dialysis. So this is all about management of the AKI. Like management of the AKI, like may appear very short, but basically we have to treat the etiology. That is what the main management is. So just a last slide to show you what is given in Harrison. So management of AKI. If you see, the first point is stabilize the patient hemodynamically, avoid the nephrotoxic drug, start dialysis. That's all. So coming to etiology specific, rhabdomyolysis, we have to give aggressive IV fluids. Tumor lysis syndrome, again IV fluids. Allopurinol can be used. If there is a volume depletion, start with if there is a volume overload, start with the diuretic, fluid restriction. Hyponatremia have to be corrected. Hyperkalemia, you can give calcium gluconate, insulin, nebulization, and K-bind sachet and all can be given. For metabolic acidosis, if pH less than 7.2 or bicarbonate less than, what is the absolute indication for dialysis? pH less than 7.1, bicarbonate less than 5, you have to take for dialysis. So you have to basically give a conservative therapy for acidosis, hyperphosphatemia, hypocalcemia. Magnesium have to be taken care of, nutrition have to be taken care of. It is a general guideline overall to manage a patient in ICU, looking at the electrolytes, volume status and the uremic status. So this is all about AKI. I tried to give in a compact way, and I will make one more video regarding AKI with respect to what is given in Harrison and what are the information jumbled in Harrison.